So my presentation is called Health Equity with Intentionality. And I have to say that I have struggled with this title because, as you can imagine, intentionality suggests that we can be very proactive in addressing health equity. But it's actually spurred by my level of frustration in terms of the healthcare system and what we have not done in terms of achieving the elimination of health disparities. Could an alternative title be, How is Medicine Complicit in Reproducing Disparities? And I ask you to reflect on that. Or alternatively, how does medicine actually produce healthcare disparities? So when we look at health disparities, oftentimes we look impassively and say, there's a phenomenon when we have population groups that continue to meet a historic gap with regards to care. And thus, we have to fix things. The American mentality is all about fixing things and thinking about, oh, there's something that needs to be addressed here, and how can we fix it and retrofit? I really believe that the answer for addressing health disparities is not about retrofit thinking. It's not about retrofit thinking. It's about thinking about this with intentionality, with commitment, and thinking about why equity should be at the core of how we design a healthcare delivery system. Now, as I understand, your theme for 2014 was about mentorship. I wanted to identify two of my mentors. The first mentor is Dr. Frank Staggers, as you can see on the top. Dr. Staggers was the first African-American president of the California Medical Association. He sadly passed away about 3 months ago. He was an icon in California and the Bay Area, and certainly was a mentor for me, being a very generous man and also having the line of sight in terms of what it meant to think about the most vulnerable in our communities and leveraging the power of the California Medical Association, the power of convening to engage people into a more deliberate discussion around disparities. And then secondly, I always think about my patients, which I think is a natural for you all. I think about my patients, and I still see patients at a community health center in Oakland, Chinatown. And this is not a picture of a particular patient, but I will say when I hear about the 82-year-old woman that I'm taking care of, and she tells me the story that she's still working, and what does she do? She cuts threads off of garments, and she makes 25 cents an hour. And I say, why do you do this? You don't have to be cutting threads off of garments for 25 cents an hour. She tells me, because I still want to be worthwhile and I still want to contribute. That's the mentorship that I get by seeing my patients. But let's go back to the topic of equity with intentionality. I don't know if you've ever seen this slide. It is a slide looking at black-white standardized mortality rates through not just the last 10 years, not just even one generation, but actually 2 generations. And if you go back or you go forward, that trend line is pretty static. It is a trend line that shows that we have no variation in terms of the black-white mortality across this country. And as much as we've been talking about the issues of social justice and healthcare, this line is stubborn. It hasn't moved. It hasn't deviated. And I think we all need to ask ourselves, why has it not? Why has it not? If you look at the next slide, there's been a lot of discussion around the social determinants of health. And at the Institute of Medicine, we're actually promoting the WHO's perspective that if you look at ultimate health outcomes, it's about where people live. It's about behaviors, representing 40% of the equation. It's about family history and genetics, 30% of which we have very little in terms of being able to modify. And maybe 10% is associated with what we do on a day-to-day basis in terms of providing medical care. So, that's kind of the big calculus with regards to how to look at health outcomes and, dare say, health disparities. And I believe this, the social determinants of health, educational opportunity, income opportunity, social fabric in a community, these are all important. And these are perhaps the main levers and the main gears with regards to health disparities. But I will point out, when I look at this slide, that this 10% of medical care, it has a lot more torque than we realize. And I'll just say it very crassly, 18% of the GDP is associated with this monster of medical care. So don't think because we ultimately 10% result in the equation for better health outcomes, or in this case, premature death. 10% in terms of what we do and how much we consume in this country with regards to healthcare has something to do with healthcare disparities. And this is my message around this particular slide. It's not for us to say, as healthcare providers, well, you know what? It's all about social determinants, so there's not really that much I can do. The fact that people have different clinical outcomes with the populations that I care for. I believe we do have something. We have something to be accountable for. Healthcare deliverers, healthcare providers need to be accountable for the formula. For the fact is that you use 1/6 of the nation's income. Now, if you look at the issues of healthcare disparities, one could say, oh, it's about prevalence. People have different prevalence of disease. We can't help that. But if you look at these statistics in terms of heart failure hospital admissions, diabetes admissions, admissions for asthma, there's something about you, about me, about the healthcare delivery structure that continues to fail, especially in family medicine, in that we care for ambulatory patients generally. 90% of our business is about caring for patients in the outpatient setting. Well, why do we have disparate admissions across the board for very serious diseases among African Americans and Hispanics as compared to Caucasians? So there's culpability that's involved here. It's about what we have done or have not done with regards to addressing these issues. The question is, how do you ever think about addressing these from the very get-go, as opposed to thinking, I got to fix this and I have to retrofit it? So, you know, the Institute of Medicine came out around year 2000 with the oft-quoted 6 pillars of a quality healthcare system. And I actually learned to memorize the 6 pillars, I hate to say. Safety, timeliness, effective, efficient, equitable, and patient-centered. Now just think about it. Since the quality chasm came out in year 2000, all this activity that you've been involved in, how much work have we done with regards to the patient-centered medical home? We have poured tens of millions, hundreds of millions of dollars and resource hours, healthcare teams thinking about patient-centeredness. We've been thinking about checklists, you know, in the operating room for efficiency, for safety. We've been thinking about ways to reduce surgical site infections to be effective and safe. How much work have we really been doing on equity? When's the last time you saw a national set of practices addressing the question of health equity? And you know, it's a very difficult question. People say to me, well, you know, probably equity is woven into all these things. If we achieve safety, we'll achieve equity. If we achieve timeliness and patient-centered, we'll achieve equity. I actually submit it's the other way around. If you think about equity as the basis, the prime objective of what you need to do in terms of designing a healthcare system, you're going to more likely achieve the other 5 parameters, the 5 other pillars, as opposed to thinking, oh, by the way, we looked at equity when we looked at safety. Now, we come out with these reports. The National Healthcare Quality Report comes out from the Agency for Healthcare Quality and Research every year. We have a national report card with regards to how we do in quality. And we measure this and we look at it very closely. Every healthcare system, every healthcare insurance company, every health plan fastidiously looks at the annual report from AHRQ. And then we have these major initiatives. And here was one that I was somewhat involved in. I don't know if you recall the 100,000 Lives campaign put together by the Institute for Healthcare Improvement. I'm sorry, it was just a little fuzzy. But, it was all about things that you could do at the hospital to reduce the mortality rate in the hospital, whether it was ventilator-associated pneumonias, surgical site infections, etc. It was about some is not a number and soon is not a time, which I really believe showed us that if you put forward a systems approach, you can make a difference of 100,000 lives. And the Institute for Healthcare Improvement, Don Berwick, demonstrated that if you put together thousands of hospitals together, the thousands of medical care teams, you could achieve a reduction in mortality of 100,000 within hospitals. Could we do the same thing with regards to health equity? Could we do the same thing? If you look at a follow-up report to the Institute of Medicine in the year 2000, about 2003 came out unequal treatment. So unequal treatment was ostensibly about the Institute of Medicine looking at the evidence with regards to whether disparities exist. And like most things that the Institute of Medicine does, and I have to say, I'm affiliated with the Institute of Medicine, we state kind of the obvious. But we state it because we look through the literature and we assemble a group of supposedly folks that, really are impassionate and just look at evidence. But even if you look at the right-hand column, even if you were not a person that believes in social justice and believes in the ethics that populations should not be disparate, you're going to be convinced around the economic impact of disparities. We're not talking billions, we're talking trillions. And we're not talking about just a few lives. We're talking about many lives and the impact of, in this case, 30% of direct medical care costs associated for just the difference in expenditures for minority populations related to health inequalities and health equity. So if I had to convince you, just from an economic point of view, you would put your money on around how to achieve health equity. Now, the National Healthcare Report also has kind of a companion report. The National Healthcare Disparities Report, also put out by the Agency for Healthcare Quality and Research. Have any of you seen it? Okay, I got to tell, it used to be Carolyn Clancy, but she left. Actually, what I heard was this report is downloaded more often than the Healthcare Quality Report, which is encouraging. But this is a very interesting chart on the right side, because they look at hundreds of different measures for different minority groups as compared to Caucasians. As you can see here on the different columns, black versus white, Asian and PI versus white, American Indians, Alaska Natives versus white, Hispanic versus white, and the relative number of measures that are improving the same or worsening. It's pretty easy to see that the majority of those bars are blue or dark blue, meaning they're not improving or they're even worsening. So it's pretty clear if you look at the evidence with regards to the quality measures that are reported in the National Healthcare Quality Report, we are not making progress on disparities. We are not making progress. The majority of measures are either at the same or worsening. That 1.4 adjusted mortality rate is not changing. It's not changing. Now, does the Affordable Care Act provide the answer? Well, if you look at the Affordable Care Act, it's about coverage, largely. There are aspects of looking at patient-centeredness and looking at disparities much more deliberately. But it's not the blueprint to achieve the elimination of disparities. I want to look at something in terms of looking at a very specific example. And this is what we do every day when we're in clinic. We take care of high blood pressure. And you know, the high blood pressure control rates across this country are miserable. It's barely 55% control. But if you look at just the Black, Hispanic rates of prevalence and control, particularly control, you can see that in this case, Mexican Americans, African Americans don't have the same control rates as Caucasians. We all see this, we all know this. The question is why, and what do you do about it? And how do you systematically think about it? Why are the stakes so high? Because it's not just a question of disproportionate prevalence. It's not just a question of disproportionate lack of control. It's about disproportionate mortality. So you look at this chart. Overall mortality for African Americans versus non-Black rates for hypertension, 6 to 13 times greater. I like to say it's not about a different country. This is about a different universe. When we have high blood pressure rates that result in a mortality rate in the double digits fold over Caucasians. It is not only a question of disproportionate prevalence, disproportionate lack of treatment. It's about disproportionate mortality. And on top of that, if you go underneath the data, you'll see that the folks that are most disproportionately impacted are young African American men. Between the ages of 35 and 55, in their prime age, their most productive ages, they have by far the worst outcomes when it comes to hypertension. Why do we live with this? And how do we live with it? And how do we address it? That's really the question. As an example of looking at a question of health equity with intentionality. So, what do you think about it? When you look at your own population groups and you think about hypertension, what are the typical ways that we try to address that? We need to get education out there. We need to have more blood pressure monitors in the community. We need people to self-monitor their blood pressure at home. We need to have more minority faces in our literature. We need to have more minority physicians who are taking blood pressures. We need a better healthcare team. And in this case, and I just plucked this out, we need to talk about nutrition. And you know, the DASH diet is being associated with improved outcomes for hypertension control. In this particular study, significant improvement in blood pressure tied to greater adherence to DASH diet from the Journal of Academy of Nutrition and Dietetics report. African Americans less likely to adhere to the DASH diet for lowering blood pressure. Is that an answer? I would not say this is not valuable. It is indeed valuable. And it's important for us to integrate all these issues around thinking about culture, linguistic access, cultural competence, thinking about ways that we get more in touch with people in terms of their daily lives. But it's all about fixing people, and it's about retrofitting and band-aiding something that we've never paid attention to. Because if we really looked at how you could take care of blood pressure from an equity point of view, you explode all the myths and say, look, we are not going to live with blood pressure rates that are different across different population groups because the science is there, we know what medications work, and we know how to control it. I looked at a report that just came out a few months ago. One of the authors was Marshall Chin at the University of Chicago, who's done a lot of disparities work. And they looked at all the literature in the last 20 years that's reported on what you can do with regards to disparities. And they did a taxonomy of what the literature said. This was their conclusion. The majority of disparities interventions in the literature use education to influence the knowledge and behavior of patients. Researchers and providers are focused on changing patients rather than the system that serves them. Rather than the system that serves them. So there's something about our mentality about we're going to fix something here, and it's about how you react to us. Because we're not going to question the basic premise in how we put our healthcare delivery structure together. We're not going to question about why is it that there's a systematic lack of commitment to address something like high blood pressure, and particularly around minority populations that have a disproportionate share of suffering. This was a study that was done at Kaiser a few years ago. And I just clipped it. It's, obviously it's not the best slide for a presentation, but the title was Health System Factors and Antihypertensive Adherence in a Racially, Ethnically Diverse Cohort of New Users. And what is highlighted here is, in research language, when you looked at the African American Black members at Kaiser Permanente, fully insured population, that the effect of copayment had a disproportionate burden of making decisions in terms of adherence among African Americans as opposed to other populations groups. There's also some impact among Hispanics and Asians. But that's a system-level question. It's not about, Mrs. Jones, did you put too much salt in your food today? Not again to say that that's not important, but I think it really raises a question around looking at system levels of intervention and how we can intentionally address health disparities. Now, this is, again, a slide that's not perfect for a big PowerPoint presentation, but I thought it was really compelling. I just got it last week, and it's about taking blood pressure for African American men in barbershops. And I don't know how many of you have heard of this intervention, but this is Mr. Tony Harris down in Southern California, and one of the interesting comments he has. So the blood pressure is taken by a barber at the barbershop, okay? And Mr. Harris says, at Wally's, having my blood pressure measured on a regular basis at Wally's keeps the information steady. Those numbers don't lie. Plus, the program is conducted by a reputable hospital. Doing it in a relaxing atmosphere of Wally's barbershop is almost like going to the doctor and getting my hair done. God, what have you thought about your interactions in your clinic? It's about an interaction like this patient has with their barber. But maybe it's not about your venue. Maybe it's about getting to the places where people are at. And I don't know how many of you visit, for lack of a better way of putting it, a black barber shop on a regular basis. Black barber shops are not about vanity. They're about men who make a commitment to feel good for themselves and for their family. And so if we connect to people where they are and we question the values in which we think of something like high blood pressure, I think we have a lot more traction. We have a lot more traction in terms of addressing something like high blood pressure. I'm not saying that's the be-all, end-all, that's the answer. Obviously, it'd be so simplistic to say that. But I think it does call into question the presumptions that we have with regards to taking care of something like high blood pressure, i.e., come to see me, and I'm going to tell you how to do a DASH diet so it's more relevant to you changing a behavior, as opposed to thinking about the system and how it addresses where people really are at. Where's the success story? I didn't mean to be self-serving, but Kaiser Permanente is doing work on blood pressure control among African Americans. And as you can see here, we actually do really well around blood pressure monitoring. We actually had an article in August of 2013, talked about our systematic approach to blood pressure. The dark line is the 90th percentile for HEDIS, okay? As you can see, the green line is where all our members are at. And the purple line is African Americans. We had a Kaiser Permanente exclusively for African Americans, we'd be above 90th percentile for blood pressure control. But it's not good enough. Not good enough. because their gap here, as you can see by the bars inside, started at 7%. That is not good enough. We made a commitment to decrease at least by 50% over the course of 2 years. So we've made good progress. Okay? But, you know, I have this conversation with NKP. People say to me, Dr. Wong, we're never going to get rid of disparities. In fact, we already reduced 50% of the gap between African Americans and Caucasians in terms of blood pressure control. Well, the fact is that's not good enough. That's like going to the moon in Apollo 10 and saying, you know, we got within a mile of the surface of the moon. Let's turn back and say we can do it if we wanted to. We got to get to the surface of the moon. We got to eliminate the gap. And we got to think about it in terms of systems. And we're employing all these issues. We're looking into the barbershop things. We're looking in terms of the co-pays. We're looking at systematic elements. Let's bring another example. So as I mentioned, I used to be a physician at a community health center in Oakland, Chinatown. And I think many of you know about hepatitis B and its disproportionate prevalence of carrier state among Asian Americans, which is refreshed every year because we have many incoming immigrants from countries that are endemic for hepatitis B. Now, the reason why I show this was back in 1987, I was part of a CDC cohort of studies to look at the ways that we would address hepatitis B. Now, hepatitis B basically involves shots, getting shots to people, kids, babies, mothers, people that are at risk. Now, if you thought about that, it's pretty straightforward. People come in, visit, we give them the right shot, right? Well, we at Asian Health Services actually realized there was a lot more involved in that. Because our mothers came in not knowing their hepatitis B status. We had healthcare teams work with the mothers in their language, whether it was Laotian, whether it was Cantonese, whether it was Vietnamese, whether it was Korean. And we didn't just say, this is what hepatitis B is about. We said, you need to advocate that as soon as your baby is born in that hospital, do not let those nurses go without immunizing your kid, your baby. We made sure that the linguistic barriers were proactively engineered not to be a barrier. We had labor coaches go with those mothers, not only to help them through labor, to say to the nurses, you know this mother's hepatitis B surface antigen positive. And we also told in front of the chart, they used to carry their own prenatal chart with them to L&D, and it said hepatitis B vaccine needed for baby age big at birth. There was no chance for these patients to fall in between the cracks. And we also say, do not tell us that the patient didn't understand because she understood. And do not tell us that it's not covered in the Medi-Cal. We covered that. Do not tell us that you didn't have enough vaccine that day. Do not tell us that they didn't sign consent because the consent was signed and in front of you when they went into the hospital. The financial barriers were removed. There was transparency in the process, and then we cultivated the lessons. So I used that example because it wasn't about, hey, this is the evidence. Hepatitis B vaccine, let's get it to the babies. It's about manufacturing, engineering, designing intentionally about how to eliminate a disparity before it ever happens. What happened? The incidence of acute hepatitis B from 1982-2006, I mentioned that the cohort of studies I was involved in 1987, what happens in 1987 here? See, it's starting to see a dramatic drop in terms of acute hepatitis B infection. You look at the racial and ethnic disparities. Again, this is broken down for the different minority groups. The incidence way back in 1990, if you look here, the Asian Pacific Islander, 12. And as the program got rolled out, you see a dramatic drop. So I do think that disparities can be eliminated. I do think that we don't have to think about how do we fix things when we see disparities and and design retroactively. I believe that we can get to the elimination of disparities by engineering from the very get-go. And the other important thing about this particular slide is, if you do it right, everyone benefits. Everyone benefits. Because if you build with an equity at the very beginning, it will accrue the benefit of safety, effectiveness, efficiency, patient-centeredness, timeliness. And it will accrue benefit for the overall population, because you can see here the Hispanic rate went down, the African-American rate went down, the Caucasian rate went down. And now, 25 years later, it is standard of practice. We have to look at opportunities where the standard of practice was built on an equity lens. So what about the opportunities to fail? The opportunities to fail. And it comes at us all the time. You have to think about this. Every time an opportunity to introduce technology and screening, new therapies, there's an opportunity to create a disparity. So I use this example, and you probably even talked about it at this conference. The level B evidence from the United States Preventive Task Force that suggests that low-dose CT screening is valuable to screen patients who are at risk for lung cancer because of their smoking history. And if you look at the graphs here, with regards to the red line, cancer rates, lung cancer rates, specifically among African Americans, male and female, are much higher than everybody else. The question is, if we institute the level B recommendation, offering low-dose CT scans for people who have a smoking history, how well do you think African American individuals are going to get that screening? Are they going to be the ones that were reached out to? Are they going to be the ones that are going to self-advocate? Are they going to be the ones that the physician went out of their way and said, you know what? This CT screening is valuable. It could prevent you from developing lung cancer. I'm waiting for this disparity to actually happen if we don't think about it intentionally. And I would challenge you to think about these other ways that the healthcare delivery system, medicine, is culpable in producing disparities. So there has to be some accountability in how we think about the evidence and how we think about opportunities to, quote, improve healthcare when we actually create disparities. So this is to sum it up. And certainly, if you have energy, we can talk about this a little bit more after I finish. We have to really design programs that take into account the vulnerable. Not design programs that take into account the insured, or the well-heeled, or the well-educated, or the well-secured. We have to think from the denominator of the most vulnerable. We have to uphold principles of health literacy. And we could have done certainly a couple of sessions on health literacy. But health literacy is a two-way street. It's not about the dumb person on the patient side that doesn't understand what you're saying. It's about how effective we really are as providers in terms of getting to the point of convergence where it means something to a patient. We have to consider high sensitivity indicators and actions. And I borrow this term, of course, from whether a test is highly sensitive or highly specific. It's really in terms of what actions, interventions do we take up, do we design, that are sensitive enough to capture as many people possible that are vulnerable to that condition. We have to challenge prevailing assumptions around health behavior and choices, especially those that reflect our own values. So take the question of screening. If you offer the opportunity for a Latino man, why don't you come in for your colonoscopy because you're age 55 now, and we'll look to see if you have colon cancer. For many, that's saying, okay, that sounds reasonable. But for another person, screening means looking for something that may or may not be there, as opposed to saying it's important for us to make sure that you don't develop cancer. Even the connotation around screening and treatment has a lot of different messages for different populations groups. We always have to assume diversity, and we have to incorporate inclusion. And, you know, I've been talking about race and ethnic populations, but certainly when we see a patient, and I'm sure you talk about the range of sexual orientations, the range of sexual assignment. We can't assume that this person right across from us is straight. Can't even assume that person is gay or lesbian. We have to assume the whole context of the human condition. We have to design for differences in access and financial means, which is pretty self-evident, which I used in my earlier examples. But, you know, we tell people, oh, you can pick up some naproxen at Walgreens, and it'll be good for your knee pain. When's the last time you looked at how much naproxen costs at Walgreens? It's $10. And for some people, $10 is just not within the reach. How many times do we ask? I always tell my patients, you could buy that at Walgreens. It'll probably cost you about $15. Do we recognize whether the patient says, yes, that's okay, or, you know what, that's kind of expensive? But we assume because $10 or $15 for us is 3 Starbucks, everybody can afford that. We work to incorporate the common denominator. And this is where the common denominator works for the overall good, as I showed in the hepatitis B. What's the common denominator to achieve success? Where do we identify where most people can come on board? We have to anticipate the cracks in the system. And I used that example of hepatitis B. You have to think proactively about every interaction that patient, that community faces in terms of accessing health care and accessing treatment. Don't let the cracks be the system. The cracks should not be part of the system. And we have used this kind of engineering principle around the checklist and operating room. It means there's no cracks. Why don't we use the same approach? There should be no cracks in terms of how people are able to achieve screening and treatment for chronic disease. We can't assume that it's chance whether that person adopts the DASH diet, doesn't adopt the DASH diet. So now I want to show you something personal. My dog. And actually, I'll be very impressed if any of you can recognize this breed. It's a pretty rare breed. That's not actually a picture of my dog, but he really looks like this. This is a Jindo, a Korean dog. It's one of the national treasures of Korea. But I like the picture because, one, I like looking at my dog. But it's also a reminder, we need to be alert. We need to be vigilant. And we need to be ready in terms of really being serious about addressing disparities. We need to be intentional. We need to be intentional about achieving health equity because it will not happen by accident. It happens with proactive thinking. It happens with engineering. It happens when you make it your prime objective, when you look at the opportunity to improve health and the care of our communities. It is not a second thought. It is not about marginalization. It's not about fixing things. It's about making the right thing the first thing you do around equity. And I know this group is a powerful group of individuals that can catalyze that thinking throughout all the healthcare systems throughout our country. So thank you for allowing me to share these thoughts with you.